physical exercise. There's quite good research out there now that physical exercise, moderate physical exercise, we're not talking about, about very, very challenging sportive activities, but moderate physical exercise, cardiovascular exercise, is a mild antidepressant, and it also helps in PTSD sufferers. There are some good studies out there. I mentioned here the Rosenbaum review paper. Now let's conclude. We spoke about the commonalities and the differences of the empirically supported psychotherapies, and my point would be that the commonalities really outweigh their differences, which is a good news, because none of us will be able to learn all those approaches and apply them in a professional way. So there are much commonalities. We spoke about those commonalities: psychoeducation, emotion regulation training, exposure, cognitive work, work with emotions, and also about the reorganization of memory functions and creating a coherent trauma narrative. Then we spoke about emerging treatments, psychedelics, mini interventions, 3-MDR, acupuncture, and somatic experiencing. And finally, and that is my personal view, of course, I think psychotherapy for PTSD should really be complemented by interventions that aim at promoting resilience. Now, this is a little bit of promotion for our own books. This is a book I did together with Marilyn Cloyter about evidence-based treatments. This is the second edition of 2022. And the same for in the treatment for children and adolescents, where Marilyn Cloyter and I joined with Markus Landolt from Zurich. And we are just about publishing the second edition. It will come out in early 2025. Now I will end with a Chinese proverb. Grant yourself a moment of peace, and you will understand how foolishly you have scurried about. Learn to be silent, and you will notice that you have talked too much. Be kind, and you will realize that your judgment of others was too severe. And with that, I thank you for your attention.
Thank you. I think we can send reactions if we want.
How do I now go back?
While you stop your presentation, maybe we can.
I stop presenting. Yes.
Yeah. So I see already a couple of hands raised. So first, Mary, maybe. And then also, yeah. Okay, so Mary, please, your question. Mary, L, if you want, you can ask the question. I see your hands.
But you should put on your microphone.
Yeah. Or if you prefer, I can read it. If you can put it in the chat, and I can read it as you like. Okay, so you can write it down in the chat, and I will be happy to translate if you need to Professor Schnyder. While Mary is okay, so Mary wants to thank you and know if you can have some references to share in order to be, I think, updated on the topic, or maybe I think you should your email address, so maybe people, or if you want, you can send me a reference list if you want, Ulrich, and then
Well,
I can share it to.
Well, I'll be happy to share my email address and respond to people if they approach me directly. That is one thing. And I can also share the slides, and I have some references on the slides also. So maybe that would be helpful.
Yeah, yes. Yeah. Okay. Another request. Yes. So, Caroline, you can.
Yes, thank you so much. Thank you, Professor Schnyder, for this really very informative talk and for that overview of all the different approaches for treating patients with trauma symptoms. I was just wondering, because you were not speaking about multi-component treatment, you were only speaking about the single psychotherapeutic approaches. What is the role of multi-component treatment in treating patients with trauma-related symptoms, and what is important for the clinical work, and what is also important for doing research when we are having this access to multi-component treatment settings?
Can I, before I say something about it, I'm not quite sure what you mean by multi-component treatment.
So, I mean, an inpatient department where patients having different modules of treatment include not only psychotherapy, also relaxation techniques, activities, exercises, and art or music therapy.
Yeah, okay, thank you. So I understand. So this is something that is usually done in an inpatient setting, of course. And as you probably know, there are a number of specialized trauma wards in most, at least in Switzerland and in Germany as well, wards in general psychiatric institutions. And what they usually do is that they combine evidence-based elements, which I talked about, you know, in terms of drug treatment and psychotherapy, with other components that are maybe less strongly evidence-based. I mean, all those creative therapies, including, by the way, body-oriented psychotherapies, but also music therapy and dance therapy and you name it, all those other components, they are maybe not yet evidence-based. We should never forget that all these evidence-based treatments that we are talking about now, at one point in time, they were not evidence-based yet. Which means that we have, let's say, I don't know, dance therapy or something like that, which people usually don't like so much because it's not so evidence-based. We cannot say that they are not effective. They are just, their effectiveness is not yet demonstrated. And of course, it would be great to see some studies that demonstrate that they are effective as well. I personally think all those approaches that include the body physically are quite effective, but it's also methodologically not so easy to study. But this was the reason why I did not speak about those treatments. I mean, there are so many approaches out there, and I, in a 40 minutes talk, I just decided to focus on those treatments where we really know that the evidence base is quite robust.
Okay, thank you.
Thank you. Is there, okay, Giovanni Fava raised his hand, please. You are mute, so please open the mic.
We don't hear you, Giovanni. Now.
Can you hear me? Yes.
Yes.
Okay, click. So thank you for this remarkable synthesis. I was wondering, in depression, there is growing awareness that we are dealing with complex disorders, and it's really wishful thinking to believe that one course of treatment, whatever, may be sufficient to address the problems. What are your, what do you think about PTSD? And probably also, I know that you recently suggested the need of sequential modalities. Thank you.
Yeah, of course. Thank you for this question, Giovanni. You know, I am in private practice now since 7 years. And of course, I had, you know, I worked clinically before also, but I'm now really seeing many more patients. And what I can say from my personal experience, and of course, people identify me as someone who is interested in trauma, so they refer traumatized patients to me. And I have, during those 7 years, I have not seen one patient who has PTSD alone. It's just, it doesn't occur, you know. Maybe it's out there, but I don't see these people. The great majority of people, that, you know, they may have outstanding flashbacks and re-experiencing symptoms and avoidance symptoms and hyperarousal symptoms that suggest that that I can diagnose PTSD, but they all have comorbid other symptoms or other conditions. And the question really from a clinician's viewpoint is, what do I do? So how do I go about this? What do I address first? Because I cannot do everything at one time. And my approach is I try to discuss with the patient what concerns him most at this point in time. So if he is primarily suffering from nightmares and flashbacks and has maybe some comorbid, I don't know, substance use disorder and depression, but the flashbacks are the most prominent and most disturbing symptoms because he cannot function with those flashbacks, then I would start with exposure treatment, trauma-focused treatment. But if alcohol dependence or another anxiety disorder or depression is more prevalent, then I would address this problem first. And this is something that has to be negotiated with the patient, I think, and he has a say in this, of course. And sometimes it just takes longer. It's not that you know, I don't know if it's really feasible to offer one treatment for PTSD and then do a treatment for depression and then do a treatment for substance use disorder. Sometimes you combine those approaches, but you need to go about this in a sequential order, and the patient, you know, also to give you another example, some patients just don't like exposure treatment. They are afraid of it. They find they cannot tolerate it. So then you don't say, please go away, I cannot treat you. You try to negotiate with him what at this point in time would be the most appropriate thing to do. And maybe sometime further down the road, they may be ready and willing to undergo exposure treatment.
Thank you. Is there any other question? I would like to, I have a curiosity. You spoke about post-traumatic growth, and it is mentioned in the literature, the fact that growth in trauma is something which can have a value as part of psychotherapeutic approaches. So my question is, can you advise us, let's say, if you think, or based on your experience and knowledge, that there is one technique which can be more effective in producing a kind of growth in trauma rather than another technique, or if different techniques in different patients should be used in order to enrich the patient of growth besides the trauma or after the trauma?
Well, this is a really challenging question, I think, but it is an important one, of course. Let me think about this. I would say spontaneously there is not this one technique that can be applied to everybody. But what I try to do is something, maybe with most of my patients, is to talk to them about their life experiences in a more general way, and then to somehow teach them that, or teaching is maybe not the right word, to discuss with them the fact that when we approach a patient as a psychotherapist, we very frequently try to encourage them to take charge of their own lives and to seek to be more in control of what they are doing, especially in trauma survivors, because they have gone through an experience of loss of control. So of course, and I would agree that regaining control over symptoms, regaining control over interpersonal relationships, regaining control over their capability to get back to work is an important element. But there is another element that is somehow the other side of the coin, namely the idea that, trauma happens. Of course, we all think it happens to other people and not to me. However, it does also happen to me, and it can happen today or tomorrow. So loss of control is something is a normal human condition. It is maybe even more prevalent than being in control. So the idea of regaining control is somehow something that may be important in areas where it is appropriate to exert some control. But in a more general way, I think it is also important to acknowledge and to accept that many things in life cannot be controlled. Many things in life just happen to us. Good things, bad things. I mean, we fall in love, which is a wonderful thing, and we cannot control it. We are run over by a car, which is a dreadful thing, and we cannot control it. So these things do happen, and we need to somehow be able to also deal in life with situations which we cannot control. And I think, being wise would be to be able to distinguish between these two conditions. And this is something I think is important for people to somehow get in touch with their inner, with their resilience, with their inner forces and strength.
Thank you. So I don't see any other hand raised or question in the chat. I don't want to use too much of your time. So I think we can say thanks again to Professor Schnyder for sharing this knowledge and experience, and say goodbye. And I hope that other occasions will come to have webinars or on interesting topics as part of the group of research on psychosomatic activities. So thank you again, and
My pleasure, and let me thank you also. I feel honored to be the first speaker in this series of webinars, and it was a great pleasure sharing my thoughts with the audience. Thank you, Fiammetta.
Thank you, everybody, for joining us.